So am I visible and audible to all of you? Right. So one of you can reply in the chat box. Okay. Okay, there are messages. Okay. So good morning to both of you. Both are Haris, right? La. So today we are going to talk about miscellaneous topics, right? And a few of these topics, they are quite important from theory as well as practical point of view. So today we are going to talk about 5 diseases: Atrophic Rhinitis, Vasomotor Rhinitis, Rhinitis Medicamentosa, Rhinitis Sicca, and Rhinitis Caseosa. Okay. So these first 3 topics, they are important and they are quite often asked in your exams, either in the OSCE or in the practical and even in the theory. So let us go, begin with Atrophic Rhinitis. So maybe you have heard about this term, right? Atrophic Rhinitis. So something about the history. So Dr. Spencer Watson, okay, you do not need to know the names, right? So you need to know this word, ozina, right? So Atrophic Rhinitis is also called it ozina, right? And Dr. Bernard Frankel, in 1876, he described the triad of fetor, crusting, and atrophy of nasal structures. Okay, so who described it is not important for your level, right? But these features, they are important. There is fetor bad smell, there is crusting, and there is atrophy of nasal structures. And as MBBS doctors, when you're posted at your own places, right? So you should be able to diagnose this patient and treat them, right? So if you know a few characteristics and clinical features, right, it is very easy to diagnose. So introduction. So it is chronic inflammation of nose with progressive atrophy of nasal mucosa and turbinate bones. Right? So this is an important point. Atrophy of nasal mucosa and turbinate bones. So till now, all the time we're talking about the hypertrophy of nasal mucosa, but here there is atrophy of nasal mucosa. Formation of scanty viscid secretion and green color crust which emit a full odor. So this thing is called ozina, right? And removal of this crust, they reveal a roomy nasal cavity. This can be primary type and secondary type, right? Primary atrophic rhinitis. Etiology. So here is a mnemonic, right? Hernias. It is developmental, hereditary, endocrine, racial, nutritional deficiency, infection, autoimmune, autonomic imbalance, and surfactant deficiency in the nasal secretion, right? Developmental, congenital spacious nasal cavities and poor pneumatization of maxillary eardrum. Hereditary, in 30% cases it is autosomal inheritance, in 67% dominant and 33% recessive, right? Endocrine, it can be seen during puberty, menopause, menstruation, symptoms aggravated due to estrogen deficiency. Racial, it is more common in American Negroes and Latin races, the Hispanics. And nutritional deficiency in the people who have iron deficiency or vitamin A deficiency or vitamin D deficiency. Similarly, by infection of Klebsiella ozina. So this is also called P.N.S. bacillus, or there are other bacillus like Coccobacillus, Fetidis ozina, Bacillus mucosus, diphtheroids, and Haemophilus influenzae. Autoimmune, it can be autoimmune, it can be due to autonomic imbalance and surfactant deficiency in nasal secretions. So we are not going to go into detail of this. Now, secondary atrophic rhinitis. It is due to long-standing purulent sinusitis. It can be iatrogenic. The people who underwent radical turbinectomy or maxillectomy or who have undergone radiotherapy. Similarly, the people who have tuberculosis or syphilis or leprosy, in cases of rhinoscleroma and deviated nasal septum, so atrophy in the wider nasal cavity. So usually if there is a deviated nasal septum on the left side, on the right side there is compensatory turbinate hypertrophy, but sometimes there can be atrophy and that will result in atrophic rhinitis. Now this history and other things not very important for you. Now these are important, right? Symptoms, they are important. So there is nasal obstruction, right? There is greenish and yellow nasal discharge, offensive smell due to anaerobic infection experienced by relatives, merciful anosmia present in the patient, and epistaxis and crust removal, right? So you need to know in detail about all of these things, right? So we say that there is a roomy cavity or the nasal cavity is wide. So why there is nasal obstruction? So nasal obstruction is mostly because of the formation of the crust, and that crust will make the nasal cavity less patent and hence the nasal obstruction. Similarly, because of the infection, there is greenish yellow nasal discharge, right? So and they are mostly, and they combine and they form the crust, right? So you can easily differentiate it from allergic rhinitis or chronic rhinosinusitis. The discharge is quite thick, and similarly there is offensive smell, right? And this term is also important, merciful anosmia, right? And quite often you are asked this thing in your viva examination. So what do you understand by merciful anosmia? So it means that, okay, so the persons with atrophic rhinitis, the diagnostic symptom is ozema, right? The foul smell. So the smell is okay. In my practice, I have seen several cases of atrophic rhinitis, several, but not too many because this is not very common, right, these days. So it is so foul smelling, I know, that you feel like vomiting, right? So how does the patient live with that smell? The good thing about this is the patient is not able to smell anything, right? He cannot smell the offensive smell. So that is why it is called merciful anosmia. That means the relatives, the doctor or the caretakers or anyone else, they will be offended by this bad smell, but the patients, they are relieved, they do not feel anything. So that is why it is called merciful anosmia, right? And epistaxis crust removal. So if you try to remove that the crust, like if you see that the crust, they are causing the obstruction of the nasal cavity, and you put the venous nasal speculum and using the Tillis forceps, if you try to take it out, then it will cause bleeding. What are the signs, right? So these are the things that the patient will tell you or you'll find out, and here these are the points that you will know after the examination. So when you do a enterorhinoscopic examination, the nasal cavity is quite wide, so it is called roomy nasal cavity with atrophy of mucosa and turbinates. So whenever you see a patient do the enterorhinoscopy, right? So it becomes all clear. So you see such a large cavity. You can see even the back of the nasopharynx. You can see the posterior choana and all the structures. Okay, like the way like in the normal regular patient, when we put the endoscope and we see different structures, we see the posterior pharyngeal wall, I know, of the nasopharynx. But here we can see that all of them with our naked eyes. So there is greenish yellow nasal discharge with crust formation that begins posteriorly, and there is the foul smell, fetor, and there can be nasal septal perforation too, but not always. And there is nasal myiasis. So what is nasal myiasis? So we are going to talk in detail on this disease later on. So look here. Okay, so this is the turbinate and this is the septum, and look at the crust here, right? The crust, okay, the turbinate, this is the right side. The turbinate has become very small, atrophied, and here this is septum and the turbinate here. Okay, they have atrophied, and the crust is here, and this is the posterior pharyngeal wall. This is the nasopharynx. This is here. This border is the posterior choana. This is the posterior choana. You can see all of the structures here, right? Okay, this is typical of atrophic rhinitis, right? You have crust like this, and you feel that okay, this crust is blocking. The patient is complaining of obstruction, so why not take it out? And it should be taken out, I know, but it will cause bleeding. Exactly, and it is like this. Now this is from an anatomy class. The normal turbinates, they appear like this, right? This is the septum, inferior turbinate, middle turbinate, superior turbinate, the maxillary sinus and the antrum, and the osteomated complex is here, right? So how does it appear in atrophic rhinitis? Look here. And now compare it with this. Here, the nasal cavity is so full, right? Fuller. And here, look. And because there's so much space, it is so wide, then you can see the back of the nasopharynx. And the turbinates, they have hypertrophied, right? So it appears like this. Now, these are important. I know what is the differential diagnosis of ozina and differential diagnosis of rhinos. So, atrophic rhinitis, so that fall smell, that ozina with that discharge, it can occur in atrophic rhinitis. It can also be there in purulent rhinosinusitis, long-standing sinusitis, right? And nasal foreign body, rhinitis sicca and malignancy. Rhinitis sicca, okay, we are going to talk about it today. Now, let me tell you something about this, right? Nasal foreign body, right? So, for nasal foreign body, this is a very important question for your level, right? And the question is like this: a 4-year-old patient is complaining of right-sided nasal discharge, foul smelling for 5 days. What is your provisional diagnosis? So, whenever it is unilateral nasal discharge, foul smelling in a child or in a toddler, so it is suspect nasal foreign body almost always until proven otherwise. So these days the patients, they tend to come within a few hours of insertion of the foreign body. But like sometimes the parents, they do not know that the child has inserted the foreign body and it is there, and it's because foul smelling discharge, right? So this is also very important differential diagnosis. And purulent sinusitis, especially the discharge is greenish here and yellowish too, just like in ozina, and there is the foul smell too, right? But there are no crust, and so that is how you can differentiate. And in malignancy, obviously there is a foul smell and there is discharge. Similarly, dry nose. So whenever there is dry nose, you can suspect atrophic rhinitis, you can suspect Rhinitis Sicca, and it can be due to the history of radiotherapy, right? And it can also occur in Sjogren's syndrome. Causes of anosmia. So why there is merciful anosmia, right? So merciful anosmia is a good thing. Otherwise, the patient will die of bad smell. It is, like once you see a case of atrophic rhinitis, you are never going to forget. It is so bad smelling, right? So what are the causes of anosmia? Loss of olfactory neural elements. Okay, that is one reason. Similarly, there are thick secretion and crust over the olfactory area, so that the air or the bad smell, it won't go up to the olfactory area. And there is the degeneration of secretory glands, scanty mucus for dissolving odoriferous materials, right? Okay, and what are the causes of nasal obstruction? So blunting of the sensory nerve endings, crust formation, and the lack of eddy current formation in the roomy cavity. So look here, this is a normal nasal cavity, and when we expire, I know. So when we inspire, it is in the laminar flow, but when you expire, the turbinates and all of these structures, they call it eddy current, but the eddy current is not present here. So that is why there is a sense of nasal obstruction. Pathology. What is the pathology? Accumulation of lymphocytes and plasma cells, squamous metaplasia from ciliary columnar cells, and ciliary destruction and decrease in nasal gland secretion, and bony reabsorption. And these are again of two types, type 1 and type 2. So we skip it, right? So what are the different investigations that you can do? And investigations, it is usually a clinical diagnosis, right? But if you are confused or if you suspect some other disease, then these are the tests that you can do, right? So saccharine test, decrease mucociliary clearance time. So I have already told you about this in the physiology class. What you do is we put a drop of saccharine here, right? And after 15 to 20 minutes, it can be tested in the oropharynx. So it denotes that the ciliary function is optimal. And because atrophic rhinitis is common in malnutrited patients, so you can send for serum iron and protein levels. Similarly, culture and sensitivity of nasal discharge to see if it is a case of purulent sinusitis, and also diagnostic nasal endoscopy. Okay, it is a part of clinical examination these days, and then X-ray to look for maxillary sinusitis. So diagnostic nasal endoscopy. Okay, now you already know this patient and you already know this doctor. You have seen them for so many times. Now CT scan. Okay, CT scan is very important to diagnose nasal disease, and it will also help us to rule out any other conditions like malignancy and anything like that. So there is mucoperiosteal thickening. You can see it here, mucoperiosteal thickening, right? Resorption of ethmoidal bulla and alcinate process. The ethmoidal bulla and alcinate process, they are here and they are absorbed. And look here, the maxillary sinus, it has become small. So there is hypoplasia of maxillary sinuses. And look at the size of the nasal cavity, roomy nasal cavities. And erosion and bowing of the lateral nasal wall. Look here, there is a bow-like formation, right? And the turbinates, they are atrophied, right? Look at the size of the nasal cavity. Now, specific investigation. So you know that there are two types of atrophic rhinitis, primary and secondary. So in secondary, there can be a lot of causative causes right? So that is why you sent for chest X-ray to look for TB or bronchitis or lung abscess, serology, BTR, TPFA, and TPI, sputum for AFP. Okay, so these are the investigations. We usually do not do these investigations, right? So what is the medical treatment? Okay, so this is very important because in your setup, I know you can easily prescribe this medical treatment, and because it is very easy to diagnose, so you can well treat the patient at your own center. So this is how you treat, you know, because and like this requires a mixture of a lot of treatment regimes, but it's not necessary that in all the patients you will require all these things, right? So you can try whatever is available at your place. So the most important among all of the treatment management is the nasal dosing, right? So it is alkaline nasal dose, and I'll tell you how it is done. Similar to ostradiol nasal spray, and glucose 25% glycerin nasal drops, streptomycin injection, placental extract injection, autogenous vaccine, rifampicin, imicetin solution, estrogen, vitamin D, chloramphenicol, and Mendel's nasal paint, and potassium iodide orally. So we usually do these things, dosing and glucose in glycerin, right? And sometimes, you know, we give placental extract ointment. And only with these things also the response has been very good. And all other things like Mendel's nasal paint and these things, they are not, you know, they are not available, but this is important from theoretical point of view. So this one thing you should know, and you should be able to explain to the patient how it is done, right? So alkaline nasal dose, it will, so what we do is we take baking soda, you know, sodium bicarbonate is nothing but baking soda, or the soda that can be put in the food, so you can get it. So remember one thing, so what we have seen in the practice, like we ask the patient, like in the OPD ticket, we write about alkaline nasal dosing, and we also write use baking soda and use sodium chloride and just nasal dose. And the patient, you know, like they go to so many shops, the medical shops, to the pharmacies to procure these things. Okay, so you should know that you need to tell them how this is made. So sodium bicarbonate, you do not get it in the pharmacy, but you find it in a grocery store, kirana dokan ma So similarly, sodium chloride, right? This is table salt, right? So the patient needn't go looking for it in a pharmacy. It is found in the kitchen or in the grocery store. So what you do is, so you take a part of sodium bicarbonate, okay, 1 teaspoonful, and half teaspoonful of salt, and then you mix that in a glass of water, okay, of this size, right? A glass of water, roughly 280 ml, right? And then what you do is ask the patient to take a syringe, 50 ml syringe, right? and you make a catheter, it can be made in so many ways, so you have the IV set, so you can take a part of the IV set and just fix it to the syringe and ask the patient to draw that water in the syringe and do the nasal dosing. A part of baking soda and a part of sodium chloride mixed in a glass of water, and use this to irrigate the nasal cavity. It is better if the water is warm, and ask the patient to do it by bending forward, and when he is doing that, ask him to say "Ka." So doing that, the nasopharyngeal muscle will be closed, and hence all the water will come out through the nose itself. So it can be initially it can be done twice a day or even thrice a day, right? But as the disease improves, so it can be done once a week or twice a week or thrice a week, just as required. So this is very affordable, quite cheap, and very easy. So this is probably the mainstay of the treatment, right? Alkaline nasal douching, and we do this alkaline nasal douching in so many conditions. In the patients who have underwent endoscopic sinus surgery, right, or any cancer surgeries. So this alkaline nasal douche is important to take out all the crust, and also stop the formation of synechia. Action of placental extract, right? So I'm mentioning it here because it is in your book, but you just know that, right? A placental extract can be used. Surgical treatment, right? So Young's operation. So there is Young operation and there is modified Young operation. So sometimes this can be asked in your OSCE, right? So only one nostril is closed completely by raising two circumferential flaps, inner mucosal and outer cutaneous in nasal vestibule, and suturing them in the midline. So you are not asked how it is done, but the question can be, okay, what is the surgical treatment for atrophic rhinitis? And in the options, one of the options can be Young's operation, right? And then there is a modified Young operation. So because in the Young operation, the nasal cavity, they are closed by the elevation of the flap, right? The patient can't breathe through the nose and just pinch your nose and stay like that for 5 minutes, and you will find out how difficult it is, right? So it is done modified Young. So that is why there was the modification of the Young's operation. So it is done in a similar way, but there is an opening, right? And later on, recanalization is done after 12 to 18 months with a tri-radiate incision, right? The Mercedes-Benz incision, probably one of the most charming logos in the whole world, right? So the tri-radiate incision. So I have some diagrams, so they will give you a rough idea. So this is pre-operative, and this is how the Young's operation is done. The flaps, they are elevated and they are sutured or closed. And this is post-surgical, right? Now the nasal cavity is closed and the nasal cavity is also closed in the other side. And look, this is how it appears. But in modified Young's operation, small 3 mm windows are made so that the patient can breathe, right? After the Young operation has been done. And later on, after the Young operation or the modified Young operation, this should be opened when the disease has cured, right? After 1 year or 1.5 years. So you make a tri-radiate incision, just like the logo of the Mercedes-Benz, right? Now advantages of modified. So, like whenever there is modification of some surgery, so it is obviously done to work upon or to improve upon the shortcomings of the previous surgery. So here, the progress of the disease can be monitored by a nasal endoscope, right? Similarly, the glucose in glycerin drops can be instilled. Both nostrils can be operated at one sitting, and nasal breathing can be preserved. No complaints of denasal voice and better cosmetic results, right? So there are so many benefits. The function of the nose, they won't be bypassed. But similarly, in the treatment of treatment of atrophic rhinitis, we use glucose in glycerin drops, right? So we have a slide here, 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 here. Okay. So this is also an important part of the treatment, right? Apart from nasal dosing. So what we ask the patient to do is just boost the nasal cavity, and after that, instill this thing in the nasal cavity, right? So 25% dextrose, it comes in ampoule, right? Big ampoule, right? It is mixed with glycerin, so you can get glycerin everywhere, right? Even in the cosmetic soaps and in the pharmacy too. And it is mixed. And these nasal drops, they are instilled in the nasal cavities. Now there are sublabial implantation like bone, cartilage, fat, and plastipore and other commercial products. So these are done to make the cavity smaller, right? So pre-operatively it is like this, and after the operation, some implants they are kept there, right? Just for understanding, right? Look here, right? The cavity they are large, and some Teflon or some implants they are kept there, and the cavity is filled up. It becomes fuller, right? And the vestibuloplasty can be done. Aims of surgery. The aim of surgery is to decrease trauma of air turbulence, nasal closure by nasal closure and volume reduction, and increase in nasal secretions. Like by the peridrop can be implanted into nasal in the maxillary sinus. Similarly, the surgery is done to increase the vascularity of the nasal mucosa by denervation procedure and nasal implantation of maxillary sinus mucosa. Right? Now, vasomotor rhinitis, right? So this is also an important disease, and this is an important differential diagnosis of several forms of rhinitis. So that is why you need to know and differentiate know this disease and differentiate from other diseases, right? So what are the trigger factors? Very important, emotional stress, right? There is no allergen, right? No allergic exposure, but there is emotional stress. Hypothalamus controls autonomic nervous system, and by sudden change in temperature, humidity, blast of cold air, and dust. And all of these symptoms, like when you ask your patient about the history, and they will give you this typical history. Senior who is a physician, and he often calls me, and then later on we found that he is having vasomotor rhinitis, right? So he gives a typical symptom like usually when he's stressed, the symptoms they are aggravated, and because he works in a hospital that has central AC, so whenever he goes there and there is change in the temperature, he forms the aggravation. He finds the aggravation of the symptoms. Okay, so what are the clinical features, right? Symptoms are perennial, so they are long lasting. So nasal blockage, profuse watery rhinorrhea, paroxysmal early morning sneezing, post-nasal drip, turbinates, congested and hypertrophied, right? So the symptoms, they are mostly very similar to allergic rhinitis. So what we do is we do allergic rhinitis nasal endoscopy to rule out any other thing. And here you can see the nasal mucosa, they might be congested. Sequelae and differential diagnosis. So if left untreated, the vasomotor rhinitis will develop into nasal polyp or hypertrophic rhinitis or sinusitis. The differential diagnoses are allergic rhinitis, non-allergic rhinitis with eosinophilia syndrome, and rhinitis medicamentosa. So we need to differentiate it from allergic rhinitis, right? That is very important because the symptoms are very common, right? So I have these two columns, right? One for allergic and one for vasomotor rhinitis. So allergen exposure, yeah, it is there in allergic rhinitis, but in vasomotor rhinitis it is not there. Nasal itching is very minimal in vasomotor rhinitis. Sneezing is very little, right? And okay, hyposmia, and these are also very little, but rhinorrhea is increased. Similarly, nasal mucosa, in case of allergic rhinitis, it is pale or it is bluish, boggy, but here it is congested. Nasal polyps, they are quite common with allergic rhinitis, but here they can be present, right? Eosinophil count is normal in vasomotor rhinitis, but in allergy it is increased. Nasal smear eosinophil, it is increased. Skin prick test for allergens, because vasomotor rhinitis is not allergic, so there is the skin prick test is negative, and the treatment is mostly by steroid, antihistamines, and nasal decongestant. Right? And here the treatment is mostly by ipratropium and botulinum. Treatment of vasomotor rhinitis. Okay, general measures: sleep with head and elevated by 30 degrees. Sleep plus work in cool environment, not cold. Keep body warm. Regular exercise program to improve vasomotor tone. Avoidance of trigger factor. Medical treatment: ipratropium bromide spray 0.03%. Okay, intratorbial injection of botulinum toxin. Steroid spray can also be given. Topical cromolyn sodium, antihistamines, and nasal decongestant. So the similar is mostly the same, but here our choice of spray is ipratropium bromide. Right? So it is mostly given in vasomotor rhinitis, and it helps to improve rhinorrhea. Right? Because rhinorrhea is so pronounced in vasomotor rhinitis. Okay, so look here. So ipratropium bromide, it doesn't help in other symptoms, but in rhinorrhea it is very helpful, right? Vasomotor rhinitis with predominant systems of, okay, if there is rhinorrhea, sneezing, and post-nasal drip with nasal congestion, then so give topical elastin, right, antihistamine. Assuming if rhinorrhea only, then give ipratropium bromide, right? And if the response is inadequate, then you don't have to do anything. But if it is inadequate, then you can give topical chromoglycate. And still, if the response is inadequate, then consider topical agents not tried, like antihistamine, corticosteroid, anticholinergics, or chromoglycate. Similarly, if there is nasal obstruction or nasal congestion, then topical corticosteroid or mometasone is given. And if the response is good, you just stop there. If it is inadequate, then you also add antihistamine. Now, this is what we have already studied earlier, right? There are different antihistamines: cetirizine, fexofenadine, loratadine, levocetirizine, desloratadine, right? And then these are nasal decongestants, right? Phenylephrine and pseudoephedrine, they are systemic, and these are the topical: oxymetazoline, xylometazoline, and saline. Right? So we already know how they are administered: 2 to 3 drops, twice or thrice a day, right? So, and this is a botulinum toxic injection. Okay, so you Google for it, right? And there are so many benefits of Botox injection, right? It is also used in, so you must have heard about something about facelift, like what was her name? The wife of Bill Clinton, right? Hillary Clinton, yeah. So when Hillary Clinton was going for the election, so you see that, okay, and it was all over the news that, okay, she appeared younger, and like she had no wrinkles and things like that. So it is usually by Botox injection. So it inhibits release of acetylcholine and decreases rhinorrhea in case of vasomotor rhinitis, right? So you Google for it, and it is a very interesting drug, and you'll be happy to see so many uses of this. Corticosteroid sprays. Okay, so in one puff, the fluticasone, beclomethasone, and mometasone, they are usually 50 microgram, and budesonide is 64 microgram. So it is mostly 2 puffs, once or twice a day, and when the patient has improved, then only 1 puff once a day. Surgical treatment. So the treatments are aimed to reduce the size of nasal turbinates to relieve nasal obstruction, and similarly sectioning of parasympathetic secretive motor fiber of nose, between neurectomy to relieve excessive rhinorrhea. So this one surgery you need to know, and sometimes this is asked in your examination. The question can be like this: what is the surgical treatment for vasomotor rhinitis? And the answer should be median neurectomy, right? Rhinitis medicamentosa. So there is something that I told you about this in your previous class, right? So today we are going to learn more about this because this is also a very important symptom. All right, so we have a little more than 1 minute before we run out of time, and after that we'll restart this session, right? Restart again time. Okay, we wait for a while before others of you they join. So we only have 39, so that is still a good number after the restart of the session, right? So far we have studied about atrophic rhinitis and vasomotor rhinitis. Both of these diseases, they are important because either in theory examination or practical or ski, viva, anywhere, be assured that there will be one question from those two and this one, rhinitis medicamentosa. There is always one question, right? And this rhinitis medicamentosa is a favorite question for OSCE examination. Okay, so now we're going to study about this. So rebound nasal congestion due to intranasal decongestant for more than 7 days. So with prolonged use, there is tachyphylaxis. It means tachyphylaxis means it is rapidly diminishing response to successive doses of drugs, rendering it less effective. So when nasal drops, okay, the intranasal decongestant, so we get them by the names of oxymetazoline and xylometazoline. So if these drugs, these nasal drugs, they are used for prolonged time, there will be tachyphylaxis. Okay, tachyphylaxis will occur. So this will result in the need for more frequent doses, and the action of the drug will be shorter. And nasal medication containing benzalkonium chloride causes more rebound congestion than other drugs. Right, so these are the common use drugs, and these are oxymetazoline and xylometazoline. These drugs contract smooth muscles of the venous erectile tissue, reducing nasal turbinates, causing mucosal shrinkage and decreasing airway resistance. Pathogenesis, right? So you need to know. So this is interesting. So we usually give oxymetazoline to relieve the nasal congestion, but how does it cause obstruction? So the prolonged use of nasal drugs will cause prolonged vasoconstriction. There will be tissue hypoxia, and hence there will be nasovasodilation and rebound nasal congestion. Okay. Similarly, the prolonged use will cause increased parasympathetic activity, and hence nasal vasodilation and rebound nasal congestion. Similarly, longer effect on beta receptors compared to alpha receptors, and again the vasodilation. Similarly, negative feedback effect on endogenous norepinephrine and on stoppage of topical nasal decongestant, there will be vasodilation. Right. So how do you stop? So this is, this rhinitis medicamentosa is it develops because of the prolonged use, either by the unawareness of the patient or even by the medical personnel, right? So to control this symptom or to make sure that this situation doesn't occur, so there should be judicious use of nasal drops. The clinical features are chronic nasal blockage requiring increased dose and frequency of topical decongestant. So in your practice, you see so many patients, they will come and tell you that, okay, they could not sleep or they couldn't live without nasal drop, even for a single day. So watery rhinorrhea usually absent, seen only in coexisting allergic or vasomotor rhinitis. And nasal mucosa appears hyperemic, granular, and boggy in earlier stages. Treatment: it is immediate withdrawal of the topical decongestant, substitute, and this will substitute with systemic nasal decongestant, phenylephrine and pseudoephedrine, and nasal corticosteroids can be given, oral corticosteroids if the cases they are very severe, and there is something called the Rhinostat system. Okay, I'll tell you about this. And the patient should be made aware. Right? When the patient comes to you in the OPD, so this is also an important time for you to make them aware. So you have also got a social responsibility for health awareness. I know, and try to build a rapport with the patient and try to make him aware. There are so many practices that he may be observing, right? And so many things like that. So what, as a doctor or as a responsible person of the society, it is your duty to make the patient more aware. You may think that, okay, the patient has come for this, okay, I just write the prescription and send him back. So of course you're doing your duty, but that is not enough, right? So as an educated person, as a doctor, right, you also have a duty for social awareness, right? And the good thing in our setup, I know, in Nepal, India, Bangladesh, right, in South Asia, right, you know, now the things, the geometry has changed, right? But earlier, even till now, the doctors, I know, they are looked up as an authoritarian figure, you know. So the patient, they usually do what they are told by the treating physician. So use this opportunity. I know the patient may not listen to the parents, the small children, or the old people. They may not listen to their children. But when a doctor or a healthcare provider, he says this or that, the patient usually takes that advices seriously, because we are still regarded as an authoritarian figure, in the society. So the treatment for patients unable to stop topical decongestant immediately, stop nasal drops in more patent nasal cavity and use it only in the other cavity for less than 7 days. Systemic decongestant like Sinex, Sinarest, they can be used to relieve nasal blockage as the patient is weaned off topical decongestant. Phenylphenidine are used, and corticosteroid is sprayed to decrease local inflammation. So it consists of 2 bottles. First contains a patient's nasal decongestant spray, and the second has a saline solution. 2 solutions precisely combined for dosage dilution at 15% per day. Okay, dosage titration allows gradual withdrawal from nasal decongestion while maintaining nasal inspiratory flow. Right. So you do not need to do this probably. Right? So but still, I know. So it contains of a saline solution and a oxymetazoline, and this is diluted, and slowly and gradually the patient is weaned off. So this is how the solution is made. Okay, so that was all about Rhinitis Medicamentosa. The best thing to manage Rhinitis Medicamentosa is to avoid it, right? And it can be easily avoided. Especially we see the patient from periphery and from the villages, they have been taking these nasal drops for prolonged time because they are having nasal blockage, and the local practitioner, and they only have to sell their medicines, and they give it to the patient an instant relief, and he's happy. Okay, Rhinitis Sicca. Okay, now we have the last 2 topics. They are very small topics, and they're not very important, but this is mentioned because this is a differential diagnosis, right? So it is a milder form of atrophic rhinitis. It is seen in hot, dry, dusty places, usually with bakers, goldsmith, alcoholics, and anemics. Crusting is present anterior only. There is bone atrophy. Okay, the bone atrophy and fetor, they are absent, right? So now you know what is atrophic rhinitis, and just imagine that it is just a milder form, right? So there is crusting, so that is why it has been said to be the milder form. But there is no fetor and there is no bone atrophy, and the treatment is by nasal douching. And because it is occupational, bakers and goldsmith, so the change of the surrounding or occupation. And Rhinitis caduca. Okay, the synonym is nasal polystoma. Okay, chronic inflammation with deposition of foul-smelling cheesy material in nasal cavity. Nasal obstruction causes stasis of secretion and exfoliated cells, putrefaction, and caducation. So the treatment is by removal of that debris. So whenever there is debris, you remove it and you correct the nasal obstruction, okay, because that is the main pathology. So this is the end of the class for today. So we'll talk about 5 topics, right? Atrophic Rhinitis, Vasomotor Rhinitis, Rhinitis Medicamentosa, Rhinitis Sicca, and Rhinitis Sicca, right? So all of these topics are important, and make sure you go through them a few times. And these are important because this is after examination, and this is also important provisional diagnosis, right? And also differential diagnosis, right? So this is all for today, and we are nearing the end of the classes on the nose. So after this, we have a few more classes. Let me see if I take them the next week or the week after that. So you'll be informed about that, right? So students, so this will be all for today. So if you have any questions, you can ask me. So tell me something like, how do you feel about these online classes? Okay, Devendra. Okay, that is a very interesting question that you asked. How young operation cures atrophic rhinitis, right? So I have a slide on that, I think, right? Let us go to young operation. Okay. Okay. Okay, here aims of surgery. Okay, so how does it help, right? So the operation will decrease the trauma of air turbulence, you know, and it is done by the nasal closure and the volume reduction. Similarly, so these are the different methods, right? So Young's operation usually deals with this, right? And these are the other types of surgery. So the surgery will help, you know, like the air turbulence will cause the trauma. So it is expected that because of the young operation, there will be volume reduction and there won't be any trauma, and hence the you know, the nasal mucosa, it will grow and the cavity will become fuller and fuller. Right? So that is how it is done. But because it is okay. So I'll see if it is possible, because I also have to stay in the OPD and there are a lot of things to do. So we will inform you about this, right, Samir? Right? So because there are the demerits of young operation too, you know? So patient, it is so closure of the nose for 12 or 18 months, you know, it is very difficult. So it has been modified into modified young operation, right? So that is how it cures. So for a level, I know you don't need to do this young operation and things like that, I know. So the nasal douching is very important, I know. You must be able to diagnose a patient with atrophic rhinitis, and you must be able to initiate the nasal douching and other forms of treatment. Okay, Devendra, thank you for your question, and Samir, thank you for the information. Okay, then class, I'll end it here, right? Okay, then see you later in the next class.